Good afternoon, students. Today we will be discussing drugs used in migraine. So why do we need to discuss drugs used on migraine? Because we have quite a lot of burden of migraine. In the world, around 15 to 20% of women and 10 to 15% of men suffer from migraine. And in India, about 15 to 20% of the people suffer from migraine at one point of their life. The ratio between male and female in adults is 2:1. That is, the incidence of migraine in female subjects are double as compared to the male subjects. However, in childhood migraine, boys and girls are affected equally until puberty, when the predominance shifts to the girls. So what is migraine? It is a familial disorder characterized by recurrent attacks of headache, widely variable in intensity, frequency and duration. So you must remember that the recurrent headaches are widely variable both in intensity, frequency as well as in the duration of the attacks. Attacks are commonly unilateral and are usually associated with anorexia, nausea and vomiting. This definition has been given as per the World Federation of Neurology. So there are certain triggers for migraine attacks like food, disturbed sleep pattern, hormonal changes. Certain drugs can also trigger migraine, physical exertion, visual stimuli, auditory stimuli, weather changes like sudden exposure to cold or sudden exposure to heat can also trigger migraine, and hunger also can trigger migraine. So hunger meaning even hypoglycemia can trigger migraine, and certain psychological factors. So there are 4 stages of migraine. First is the prodrome, second is the aura, third is headache, and fourth is the postdrome. So what happens in prodrome is that there are vague premonitory symptoms that begin from 12 to 36 hours before the aura and the headache. So the patient can experience some vague premonitory symptoms which can include yawning, excitation, depression, lethargy, or craving or distaste for various foods. So these symptoms, many patients will ignore, but there can be the premonitory symptoms in certain migraine patients. So duration may be 15 to 20 minutes, and these are the symptoms of the prodrome in case of migraine patients, which can occur anywhere between 12 to 36 hours before the aura and the headache. What is aura? Aura is a warning or signal before the onset of headache. Some of the symptoms of aura include flashing of lights. The patient sees certain flashing of lights or zigzag lines are visible. There is difficulty in focusing. The duration can be from 15 to 30 minutes. So these are the zigzag structures which can be seen. However, in migraine there can be negative scotoma also, that is loss of local awareness of a local structure. See, there is blindness of this spot. And there can be positive scotoma, that means additional structures which are not there in the actual thing can be seen. And one side loss of perception can also be there. So these features can also be there during the aura phase. And then the headache comes. So the migraine headache, classical migraine headache is generally unilateral. And it is mostly associated with symptoms like anorexia, nausea, vomiting, photophobia and tinnitus. Photophobia means fear of light, phonophobia, fear of sound, and tinnitus means there is ringing in the ears. So all these can be there along with the headache. So anorexia, nausea and vomiting is very common in patients of migraine, acute attacks of migraine. The duration of migraine can last from 4 hours to 72 hours. So it can last anywhere between 4 hours to even 3 days. So after the migraine attack, there is a resolution phase or the postdrome. So following headache, the patient complains of fatigue. There can be extreme fatigue after the experience of severe headache along with nausea and vomiting. Some patients can experience depression and severe exhaustion. However, in contrast, some patients can also feel unusually fresh because they have rested for about 1 or 2 days. So this postdrome can last for a few hours or up to 2 days. So these are the different diagrammatic presentation of the different phases of migraine, the prodrome and then the aura and then the headache, and then we go into resolution and recovery and the normal. So these are the phases of migraine. So according to the Headache Classification Committee of the International Headache Society, migraine has been classified as migraine without aura, or commonly known as common migraine, migraine with aura, which is called as classic migraine, and complicated migraine. So what are the clinical features of migraine with aura and without aura? Without aura, as the name suggests, there is no aura or prodrome, whereas with aura there is aura or prodrome is present. In migraine without aura, unilateral tropic headache may be accompanied by nausea and vomiting, and in this with aura there is unilateral tropic headache, and later normally it becomes generalized as well. So in without aura, the patient complains of phonophobia and photophobia. So there can be, like, the patient cannot tolerate sound as well as light. So many migraine patients without aura or even with aura, they do not want to be disturbed. They want to remain in a quiet or silent room with no lights. And in this migraine with aura, patient complains of visual disturbances and may have mood variations. So what are the causes or the pathophysiology of migraine? So first is the vascular theory, in which it is believed that there is initially intracerebral blood vessel vasoconstriction, which results in aura, which is followed by intracranial or extracranial blood vessel vasodilatation, which causes the headache. So the headache is because of the vasodilatation as per the vascular theory, and the initial vasoconstriction causes the aura. Serotonin theory is also very commonly believed, and it is believed that decreased serotonin levels has been linked to migraine, and specific serotonin receptors are found in the blood vessels of the brain. So the present understanding is that there is a neurovascular process in which neural events result in activation of blood vessels, which in turn results in pain and further nerve activation, and then the vicious cycle goes on. So there is first arterial activation, and then there is release of neurotransmitters, and there is worsening of pain. So first arterial activation, and the neurotransmitters are released from the nerve endings, and there is worsening of the pain. So there can be different triggers. So even, the scalding by a boss can lead to cerebral cortex, thalamus, hypothalamus in response to stress and emotion. There can be stress and emotional changes which activate nociceptive trigeminal-vascular system and causes prolonged pain. This is one theory. And there can be abnormal neuronal activity which causes release of vasoactive neuropeptides. For example, substance B, neurokinin A. The calcitonin gene-related peptide has been commonly ascribed to the causes of migraine and serotonin. So these neuropeptides, vasoactive neuropeptides, are released, and they promote vasodilation and plasma protein extravasation. And these neurotransmitters, they initiate inflammatory response, sensitizes surrounding tissues, and produce prolonged headache. And they also in turn activates the trigeminal-vascular system, which in turn stimulate pain, stimulating neurons in the brainstem and upper spinal cord. And this activates the nociceptive trigeminal-vascular system and causes prolonged pain. So both the neural, vascular, and even the activation of the trigeminal-vascular system causes prolonged pain in case of migraine. So what are the causes of migraine? There can be because of increased excitability of the central nervous system. Then there is meningeal blood vessel dilatation, activation of perivascular sensory trigeminal nerves, which causes increase in pain impulses. And there is also release of vasoactive peptides like substance B, calcitonin gene-related peptide, or abbreviated as CGRP, and neurokinin A. And there can be combination of increased pain sensitivity, tissue and vessel swelling, and inflammation. So there can be a vicious circle of vasodilatation, the activation of the perivascular sensory trigeminal nerves, and increase in release of neuropeptides and the pain. So there can be certain triggers which there can be spreading oligomia, there can be spreading depression, the peptide release, brainstem activation, which can result in various symptoms including vestibular symptoms, the nausea and vomiting, the visual symptoms, and pain. So migraine is a multi-symptom complex. It is not just one headache. There can be other visual, nausea and vomiting, and vestibular symptoms as well. So where does the headache come from? When a headache occurs, serotonin and magnesium levels drop. So the peptides, serotonin and magnesium, has been associated with migraine, and then the trigeminal nerve also releases neuropeptides. These neuropeptides, they travel to the outer covering of the brain and cause dilatation and inflammation of the meningeal blood vessels. Dura blood vessels are disrupted, but the brain structure remains intact. And it is suggested that patients of migraine, they may be having migraine attacks for so many years, but there has been no association of increased risk of brain tumor with migraine patients. So that is a good aspect in case of migraine patients. So how do you diagnose migraine? First is the medical history. You have to have a headache diary. What is the frequency? What is the duration? What are the triggers for a migraine? And you may do certain investigations which are only to exclude the secondary causes. Like migraine, we do not have any specific investigations to diagnose migraine, but we do certain investigations like EEG, the CT of the brain and magnetic resonance imaging to exclude other secondary causes of headache. For example, a brain tumor or something which can also cause headaches. So these investigations are only to exclude secondary causes, but they are not per se for the diagnosis of migraine. So differentiating common headaches, apart from migraine, there are other headaches like tension time headache or cluster headaches. So in tension headaches, what happens is that they do not have the associated features like nausea, vomiting, photophobia or phonophobia. The muscle contraction leads to headache. Headache quality is of tightening, non-pulsating quality, usually bilateral, and intensity can be mild or moderate. In cluster headache, there is severe unilateral pain. Headache is associated with lacrimation, nasal congestion, rhinorrhea, facial swelling or eyelid edema. And the pain is normally in cluster headaches not very long lasting. It can last for 15 to 180 minutes. And these cluster headaches, they are more common in men. So these are the different types of headaches. Sinus headaches, which is pain is usually behind the forehead or the cheekbones. The cluster headache, pain is in and around the eyes. The tension headache is it's like a band squeezing the head, and migraine, there is pain, nausea and visual changes are typical in the classic form of migraine. So what are the treatment approaches to migraine? The long-term goals for the migraine sufferer is to reduce the attack frequency as well as severity, because many patients experience frequent attacks as well as severe headaches. So first primary goal is to reduce the attack frequency and the severity. Then we have to avoid escalation of headache medication. Many patients, in fear of this thing, they have to take a lot of medication, painkillers. So we have to avoid escalation of painkillers. Sometimes one painkiller used to abort the headache, but then with increasing duration, the patients may have to take 2, 3 or 4 times a day. So then you have to educate and enable the patient to manage the disorder, because certain triggers, if we avoid, then the migraine can be avoided. For example, triggers like hunger, triggers like the sleep disturbances, trigger like sudden change in temperature, or any other thing like food, certain foods. So if you avoid the triggers, then you can manage the disorder properly, and you have to improve the patient's quality of life. So in management, there can be non-pharmacological treatment and pharmacotherapy. So as I told you, identification of triggers in migraine patient is very important. You have to identify the triggers and as far as possible advise the patient to avoid those triggers. Second is meditation. It has been shown that meditation also helps in managing migraine. Relaxation therapy is also there, and even psychotherapy. So all these non-pharmacological treatment have been shown to help patients of migraine. Second is pharmacotherapy. Pharmacotherapy can be abortive therapy. Abortive therapy means you can abort the attacks of migraine, like it can be either non-specific or specific therapies, and preventive therapy means for prophylaxis. So either we have to treat the acute attacks of migraine, or we have to give prophylaxis for prevention of further attacks of migraine. So these are the types of pharmacotherapy. So what are the general advice you have to give to the migraine patient? You have to identify and avoid triggers. This is very, very important. So certain food like alcohol, red wine, or foods like chocolates, cheese, they can trigger migraine, and so you have to advise these patients, if they identify the triggers, they have to avoid it. Certain exertion can also trigger migraine. Organic, certain odors, certain patients are not able to tolerate even perfumes. So if they have identified some odors or certain perfumes, they have to avoid that. An irregular sleep pattern is very, very important to avoid in case of migraine patients. Even excessive sleep can also trigger migraine. We always think that it is a less sleep which can trigger a migraine, but certain patients have reported that even excessive sleep can trigger migraine headaches and acute changes in the stress levels. So all these triggers, if you identify, you can advise the patients to avoid these triggers, and they can improve their quality of life as well as migraine headaches. Now, second is to attempt to manage the environmental changes like the time shift zone and high altitudes, and even weather changes and barometric pressure changes. So all these things can also trigger migraine, and you have to attempt the patient to manage these changes also. And sometimes, particularly in females, it has been shown that migraine headaches are also related to the menstrual cycle and they have to take a note of it. Coming to the pharmacotherapy, there are non-specific therapy and specific therapy. Non-specific therapy is any painkiller, any non-steroidal anti-inflammatory drug can be given to control the headaches of the patient. So patient can take any ibuprofen, diclofenac, naproxen or even paracetamol if it controls a headache, or aspirin. So depending on the patient response, you can choose any of the non-steroidal anti-inflammatory drugs available and give to the patient. And certain patients respond very well to ibuprofen, or some patients respond to naproxen, and some patients are very well controlled with even paracetamol or aspirin. So depending on the patient response, you can choose any of the available NSAIDs and give to the patient when patient has a headache or migraine attack. So the NSAIDs will be dealt in a separate class, so I will not go into the details of the non-steroidal anti-inflammatory drugs. And the specific treatment include the certain class of drugs like ergot alkaloids like ergotamine and dihydroergotamine. They are specific for migraine attacks and they are given either ergotamine is given orally 1 to 2 milligram per day up to a maximum of 6 gram per day, and dihydroergotamine is given subcutaneously 0.75 to 1 milligram. And an important group of drugs, that is 5-HT receptor agonists, triptans, are also the specific treatment for migraine. The drugs like sumatriptan, rizatriptan. Sumatriptan is both available orally as well as subcutaneously. Because of low oral viability, subcutaneous injections are very commonly used, self-injectable subcutaneous injections. Rizatriptan is there. So triptans, they are the common, they are the very popular class of this thing. Hello? Batao. So triptans, they are selective for 5-HT1 receptors. The triptans are inactive at alpha-1, alpha-2 adrenergic, beta-adrenergic, dopamine, muscarininergic and benzodiazepine receptors. That means they do not have any action on these alpha, beta, dopamine, muscarinic, cholinergic and benzodiazepine receptors, and so they are selective for 5-HT1 receptors. This is an advantage because as you will know that if the drugs are non-specific, then they will have the associated side effects of adrenergic, beta-adrenergic, dopamine or cholinergic side effects. So these triptans, they are specific for 5-HT1 receptors. All triptans, they have similar pharmacologic properties but vary slightly in terms of clinical efficacy. Monotherapy may not offer complete, rapid and consistent relief, and not effective in migraine with aura unless given after the aura is completed. So what is the hypothesis to explain the efficacy of 5-HT1B, 1D receptor agonists in migraine? So the triptans, they act specifically at 5-HT1B, 1D receptors in case of migraine. One hypothesis implicates that the ability of these receptors to cause constriction of intracranial blood vessels, including arteriovenous anastomosis. So basically, they cause constriction of the intracranial blood vessels as well as arteriovenous anastomosis. So it has been seen that in a prominent pathophysiologic model of migraine, as yet unknown, events lead to the abnormal dilatation of the carotid arteriovenous anastomosis in the head. So this is also one of the causes of migraine, and so these 5-HT1B, 1D agonists, that the triptans, they cause constriction of both the intracranial blood vessels as well as the arteriovenous anastomosis. So as much as 80% of the carotid arterial blood flow has been reported to be shunted via this anastomosis, located mainly in the cranial skin and the ears, diverting blood from the capillary beds and thus producing several ischemia and hypoxia. So based on this model, an effective antimigral agent should close the shunts and restore blood flow to the brain. So triptans and the ergot derivatives, both these agents produce these vascular effects via activation of 5-HT1B, 1D receptor. So this is one of the mechanisms of action of triptans as well as the ergot derivatives. Like through the action on 5-HT1B receptors, they cause the vasoconstriction as well as constriction of the arteriovenous anastomosis. So other hypothesis concerning the significance of one or more 5-HT1 receptors relates to the observation that both 5-HT1B and 1D receptors serve as presynaptic autoreceptors and modulate neurotransmitter release from the neuronal terminals. So 5-HT agonists may block the release of pro-inflammatory neuropeptides at the space of the nerve terminals in the perivascular space. So ergotamine, dihydroergotamine and the triptans are able to block the development of neurogenic plasma extravasation in durameter, and that which follows depolarization of perivascular axons following stimulation of trigeminal nerve. So this is the second mechanism which is postulated to for these drugs to act, how they are effective in migraine, because they block the release of pro-inflammatory neuropeptides at the level of nerve terminals in the perivascular space. So this is the second mechanism which is postulated for their effect in migraine. So the ability of potent 5-HT1 agonists to inhibit endogenous neurotransmitter release in the perivascular space could account for their efficacy in the acute treatment of migraine. So these are some of the triptans: the rizatriptan, zolmitriptan, sumatriptan, naratriptan, frovatriptan, almotriptan. So all these triptans, they will like the patient is So the side effects of triptans include they are rare but serious events are coronary artery vasospasm, transient MI, atrial and ventricular arrhythmias, and myocardial infarction. Some of the minor adverse events with triptans are asthenia or fatigue, flushings, paresthesia, tightness in the chest, drowsiness, sweating, dizziness, nausea, vomiting, stinging, and pain in the chest, jaw, and the neck. Triptans are contraindicated in patients who have history of ischemic or vasospastic coronary artery disease, cerebral or peripheral vascular disease, or other significant cardiovascular diseases. They are contraindicated in patients with uncontrolled hypertension. Naratriptan is contraindicated in severe hepatic or renal impairment. Rizatriptan has to be used with caution in hepatic or renal impairment, and they are contraindicated in patients who are taking monoamine oxidase inhibitors. The triptan tips: patients have specific responses to different triptans. Responses to triptans may be dependent on dose and delivery mechanisms. Triptans work best when given as early as possible in episode, and side effects are generally mild. Serious adverse events are extremely rare, and up to twice a day, up to 3 days in a row can be given. So this is a limit, up to twice a day and up to 3 days in a row. So basically they by activation of 5-HT1B receptor in the periaqueductal gray matter. The next group of drugs, the specific abortive therapy, is ergot derivatives. They are non-selective for 5-HT1 and 5-HT2 as well as adrenergic and dopaminergic receptors. So they act on various receptors. GI absorption is erratic, so last variation occurs in patients, usually given in combination with caffeine, because caffeine has been reported to enhance the absorption of ergot derivatives, and they are available as oral, sublingual, rectal, intramuscular, intravenous, and as inhalers. Side effects include nausea, vomiting, weakness in the legs, muscle pain, transient brady or tachycardia, precordial distress, pain, and ergotism can occur. The vasoconstriction induced by ergotamine is long-lasting and cumulative when taken repeatedly. So no more than 6 mg of oral preparation may be taken for each attack, and no more than 10 per week, because of the potential side effects. And for very severe attacks, ergotamine tartrate 0.25 to 0.5 mg may be given IV or IM, and dihydroergotamine 0.5 to 1 mg IV may be given, and intranasal dihydroergotamine may also be effective. The next group of agents are dopamine agonists. They are used as an adjunctive for the other symptoms like nausea and vomiting. Drugs include metoclopramide, chlorperazine, and chlorpromazine. They are used as adjunctive therapy with 5-HT1 agonists or ergot derivatives, or in combination analgesics. They decrease nausea and vomiting and restore the normal gastric motility, because as I told you before, migraine is commonly associated with nausea and vomiting, and these drugs, they decrease the nausea and vomiting and restore the normal GI motility, and they are used for treatment of severe migraine And a common IV protocol is administration of mixture of prochlorperazine 5 mg and dihydroergotamine 0.5 mg over 2 minutes. So in case of severe, because of the severe vomiting, you may have to give a parenteral drug because the patient keeps vomiting and they are not able to take any medication orally. The anti-nausea drugs for migraine treatment include domperidone, metoclopramide, promethazine and chlorpromazine. They can be given by oral or IV or IM routes. So the abortive therapies include triptans. They are selective 5-HT1B1D agonists. The agents are sumatriptan, rizatriptan, naratriptan, zolmitriptan, almotriptan, provatriptan and elatriptan. So all these will vary in a bit in their efficacy and the effect on certain patients. So different patients will be prescribed different drugs. And the dihydroergotamines, they can be either given as nasal spray or tablets or injections. The non-steroidal anti-inflammatory drugs and the adjunctive drugs like metoclopramide or dopamine receptor antagonists, more so for the prevention of nausea and vomiting. So these are the abortive therapies commonly used for the treatment of migraine. Now, which are the patients who will need prophylaxis? So abortive drugs should not be used more than 2 to 3 times a week. And long-term prophylaxis improves quality of life by reducing frequency and severity of attacks. So if a patient has a migraine attack of more than 2 to 3 times a week, then you can consider prophylaxis, and 80% of the migraineurs may require prophylaxis. So when prophylaxis is indicated, according to the US Headache Consortium guidelines, indications for preventive treatment include patients who have very frequent headaches, more than 2 to 3 per week, attack duration is more than 48 hours, headache severity is very high or extreme, migraine attacks are accompanied by prolonged aura, unacceptable adverse effects occur with the acute migraine treatment, whether it's with the NSAIDs or triptans or ergots, contraindication to the acute treatment, and migraine substantially interferes with the patient's daily routine despite acute treatment. So if the patient is not able to do his or her daily routine despite acute treatment, then you may consider prophylaxis. And special circumstances such as hemiplegic migraine or attacks with the risk of permanent neurologic injury. And sometimes some patients prefer that, I cannot tolerate such pain frequently, and so I would like a prophylaxis. So these are the indications for prophylaxis. So what are the preventive therapy migraine? The classes of drugs which are commonly used are beta blockers, the calcium channel blockers like flunarizine, verapamil, beta blocker propranolol is very commonly used, the tricyclic antidepressants like amitriptyline, the selective serotonin reuptake inhibitors like fluoxetine. You will be dealing with these in the class on antidepressants. These are the antidepressants. The tricyclic antidepressants and selective serotonin reuptake inhibitors are antidepressant drugs. The anticonvulsant drugs like sodium valproate, topiramate, they are also commonly used for prophylaxis, and even antihistaminic drugs like cyproheptadine. So what is the role of beta blockers in migraine prophylaxis? Particularly, propranolol has been considered as the gold standard in migraine prophylaxis. It has established efficacy and safety in migraine prophylaxis, especially preferred if hypertension or anxiety coexist. So the role of propranolol in migraine prophylaxis, mechanism proposed is the anxiolytic action and the decreased sympathetic activity. However, if we give the immediate release by propranolol, it has a short T-half of 3 to 5 hours. So multiple daily dosing is required to maintain adequate degree of beta receptor blockade through the 24 hours. So there can be patient poor compliance, which may compromise the efficacy. So we have extended release preparation of propranolol. So in these migraine patients normally remain asymptomatic between the attacks. It is important to minimize the number of daily doses during prophylactic treatment, and once daily administration improves compliance and stable drug, it is able to maintain stable drug concentration for 24 hours. So the extended release preparation of propranolol is preferred for prophylaxis of migraine. So you can start with 40 to 80 mg once a day up to a maximum of 240 mg. And if satisfactory response is not obtained within 4 to 6 weeks after reaching the maximal dose, therapy should be discontinued. So you have to taper slowly to avoid rebound headache and adrenergic side effects, and the maximum duration is around 9 to 12 months. The side effects, you have dealt with propranolol in your autonomic drug classes. So there can be lethargy, GI upset, orthostatic hypotension, exercise intolerance and impotency. Now coming to the next group of drugs used for prophylaxis, that is tricyclic antidepressants like amitriptyline or nortriptyline. They are effective in prophylaxis of migraine, and this effect in migraine is independent of their antidepressant actions. They are a potent blocker of 5-HT transporter and also is an antagonist of multiple neurotransmitter receptors. So they are used in mixed headache cases, that is patients having symptoms of both migraine as well as acute muscle contraction headache. Side effects, because they are not specific only for 5-HT, so there can be anticholinergic side effects like dry mouth, dizziness, blurred vision, urinary retention, sedation, weight gain and cardiac arrhythmias are there. So they have multiple side effects, and 6 to 12 week trial is recommended before the drug is considered ineffective. The monoamine oxidase inhibitors are also used for prophylaxis of migraine. Drugs like phenelzine and isocarboxazide are used. They are used only for prophylaxis of severe migraine and reserved for recalcitrant cases of migraine because of potential side effects. Tyramine containing food, decongestants and meperidine are contraindicated when you give MAO inhibitors. Methotrexate may cause retroperitoneal or cardiac vascular fibrosis. The mechanism is by increasing the levels of endogenous 5-HT. The side effects include orthostatic hypotension, insomnia and nausea. The calcium channel blockers like flunarizine, which is a weak calcium channel blocker, is very commonly used. It may be effective only in migraine prophylaxis. So, however, other like case reports and small clinical studies have also shown effectiveness of diltiazem, verapamil, nifedipine and nimodipine. The side effects include constipation and orthostatic hypotension. The anticonvulsant drugs are also used like sodium valproate in dose of 500 to 1000 milligram once a day. Adverse effects include nausea, weight gain, alopecia and dyspepsia, and as you will be dealing with the anticonvulsant classes, they can have potential toxicity on the liver, and so any patient on sodium valproate therapy should have routine at the LFT at baseline and periodically every 2 to 3 weeks thereafter. Topiramate is also another anticonvulsant drug which is used for migraine prophylaxis. It is used in dose of 25 to 100 milligram total daily dose. Start at 25 milligram once a day to up to 500 milligram twice a day. The adverse effects are paresthesia, confusion, fatigue, anorexia, diarrhea and weight loss. So these weight loss I have asterisks because many patients complain with sodium valproate or the antidepressant drugs of weight gain with the prophylaxis. They do not want this. Particularly migraine is mostly a disease of the ladies, and so this weight loss is taken as an advantage, particularly in patients who do not want weight gain as a side effect. So the topiramate has an advantage of weight loss in patients taking this medication. So you have to start at a very low dose. Start with the night dose or hora somni dose or bedtime dose. Warn patients about the cognitive side effects and paresthesias, and beneficial effects on headache frequency often occur within the first week of therapy. So topiramate is also commonly used drug for migraine prophylaxis. Gabapentin, another anti-epileptic drug, is also used for migraine prophylaxis. The adverse effects include somnolence, dizziness, ataxia and fatigue. Gabapentin is also used in other neuropathic pain and all apart from epilepsy, but you have to adjust its dose in renal dysfunction. So these are the different classes of drugs which are used in migraine prophylaxis, like beta-adrenergic agents, anticonvulsant drugs like sodium valproate, topiramate, tricyclic antidepressants, amitriptyline, nortriptyline, monoamine oxidase inhibitors like phenelzine, serotonergic drugs like methotrexate, cyproheptadine and others like verapamil. So just to recapitulate migraine pharmacotherapy, for mild migraine where there is occasional throbbing headaches, no major impairment of functioning, and so you can just do with non-steroidal anti-inflammatory drugs or combination analgesics or oral 5-HT1 agonists depending on the patient's choice, like triptans can be given. In moderate migraine, in this there is moderate or severe headaches, nausea is a common and some impairment of functioning can occur. So you can give oral, nasal or subcutaneous 5-HT1 agonists like subcutaneous sumatriptan is very commonly used, oral dopamine antagonist because there is associated nausea and vomiting. And in severe migraine, severe headaches more than 3 times per month, significant functional impairment can also occur and there is marked nausea and not vomiting. So you may require subcutaneous IM or IV 5-HT1 agonist because the patient is not able to take the medicine. IM or IV dopamine antagonists and prophylactic medications you should consider in patients of severe migraine. So this is migraine pharmacotherapy. This another term which is called medication overuse headache. It can be caused by any acute medication And the predisposing factors, that means medication overuse headache, meaning you keep taking the medicine and you keep increasing the dose of the medicine, the frequency of the medicine, and you cannot, like every time you have a headache, you keep taking the medicine, and so there is something called a medication overuse headache. So even continuous uses of medicine can also cause headache. So what are the predisposing factors? Anticipatory fear. Many patients fear that the migraine attack is coming. So whether the attack is coming or not, they start taking the analgesics. There is a generalized anxiety, or there can be a personality disorders or genetic factors. So these factors can predispose the patient to medication overuse headache. So what is the intervention in medication overuse headache? You have to educate the patient regarding the role of medication overuse in perpetuating headache. You have to address their fear as well as anxiety. You have to provide motivation and simplify overall medication regimen as much as possible. And ask the patient to avoid benzodiazepines, and exercise have been shown to help in case of migraine patients. What are the other medications apart from the thing which we have discussed for migraine? Narcotics are effective in migraine, in acute treatment of migraine. Intravenous meperidine 50 to 100 mg is used frequently in emergency. Nasal preparation of butorphanol is used for acute pain, and the use of narcotics are however limited only in case of severe migraine. There is a newer triptan, actually it's not a triptan, a drug called lasimiditan. It is a serotonin receptor agonist that selectively binds to 5-HT1F receptor subtype. So this does not bind to 5-HT1B1D, rather it binds to 5-HT1F, and so it does not have any activity for 5-HT1B and 5-HT1D. So the lack of affinity for these receptors might result in fewer side effects related to vasoconstriction compared to triptans in susceptible patients, such as those with ischemic heart disease, Raynaud's phenomenon, or after myocardial infarction. These are some of the other agents in development. What are the alternative possibilities for migraine prevention? Like magnesium has been implicated in the causation of migraine, and so sometimes magnesium has been shown to help. Riboflavin 400 mg per day has also been shown to help in case of migraine, and even coenzyme Q. And melatonin has also been reported to help in many patients of migraine. Patients taking melatonin, maybe because melatonin also balances the sleep cycle, maybe because the disturbances of sleep is also a trigger for migraine, and so melatonin is also shown to help in case of migraine patients. The other options like zonisamide, levetiracetam, which are the newer anti-epileptic drugs, the angiotensin agents like ACE inhibitors, ARBs like candesartan has also some studies have been shown. Gabapentin and botulinum toxin has been onabotulinum toxin A. It has been recently approved for chronic migraine, in whom medication overuse has been addressed, given as multiple injection around the head, administered every 12 weeks or 14 days in a month. So this toxin given as multiple injection around the head has been approved, that is botulinum toxin A. And another drug which is CGRP receptor antagonist, adalimumab, it is a fully immunized monoclonal antibody. It has also been approved 70 mg subcutaneously once a month. So these are the botulinum toxin has been for quite some time, and these are the newer drugs, adalimumab, which is a CGRP receptor antagonist. So other treatment in the pipeline include adenosine receptor agents, glutamate receptor agents, but the CGRP receptor blockers have been approved. So what happens is that CGRP acts as a vasodilator via the cyclic AMP. So there is an increase in if there is a local release of vasodilator, local release of CGRP, which acts as a vasodilator, there is vasodilatation of the renal blood vessels, and this leads to activation of the primary afferent neurons of the trigeminal nerve, and this causes the pain. So CGRP is a molecule that is synthesized in the neuron. It has been implicated in different pain processes including migraine, and functions as a vasodilator. That is, it relaxes the blood vessels. So once scientists identified this target molecule, they began trying to develop ways to stop it from being activated at the start of migraines as a kind of abortive treatment. The oral peptides did not work to decrease the migraine pain based on certain measures like this thing, telcigapan, withdrawn due to serious side effects including liver toxicity, and these were the earlier drugs. Olcigapan, it has low oral bioavailability, and that's why it is not very commonly used. So with an increase in CGRP, which is released with triggers like sound, smell, lights, so there can be pain, photophobia, phonophobia, and nausea. So this is what happens in case, this is one of the theories, like the symptoms of migraine with high CGRP. So CGRP antagonists which are approved in 2018 include frestanezumab, which is a humanized Ig2 similar to adalimumab, CGRP receptor agonist approved for migraine prevention, and galcisinumab, humanized IgG4 CGRP receptor antagonist approved for migraine and cluster headache prevention. These are the newer CGRP receptor antagonists, monoclonal antibodies. So what is the take-home message? Migraine is common and underdiagnosed. The majority of the headaches that are presented to a particular practitioner are migraines. So it is a very common disorder and it is underdiagnosed. Sinus headache is uncommon but overdiagnosed. Menstrual headaches are mostly migraine. Neck pain is a common symptom of migraine. The central feature of migraine headache is lifestyle consistency. So it is very important to have a consistent lifestyle and to avoid all the triggers. Triptans are very well tolerated and effective. The different triptans have different profile that may be better suited to specific patients. So all these triptans you may choose according to the patient's suitability. And some newer prophylactic agents like are working well, and medication overuse. This you should always remember, this is also a primary issue in headache. Many patients will have medication overuse headache as well. So this was about migraine, the drugs used for abortive therapy of migraine and the prophylaxis of migraine. Thank you.